In this video, we're going to address some of the excellent viewer questions we had following on from the last video where we talked about the different forms of treating renal failure in intensive care. As always, if you do have any questions, please leave them in the comments section below and we can address them in future videos. So the first question is, why are the kidneys not naturally in the pelvis instead of in the upper abdomen? And it's a really good question because if you remember from the last video, we talked about how with renal transplants, the transplant surgeons put them into the pelvic brim so that it protects the kidney and also it's close to the bladder so it's easy to anastomose. So on the face of it, it seems like evolutionarily speaking, we should have moved the kidneys down into the lower abdomen. But there are a few disadvantages to that. So just to remind you of the position of the kidneys in normality, you can see that they sit in the upper abdomen and they're actually protected by the ribs. So for most blunt trauma, the kidneys themselves aren't hit directly. It is the ribs that take the majority of the impact. So actually they are relatively well protected. Of course, by putting them into the pelvis, you get the same sort of protection. So in terms of protection, they seem to be fairly equal. But then you have to consider the blood supply. So I want you to have a look, first of all, at the normal kidneys that you can see up at the top here. You can see that these two kidneys, the blood vessels connect to the aorta, which is here, and the vena cava, which is here. So the renal arteries come off directly from the aorta. So you can see that you get a huge amount of blood flow at a high pressure coming through into the kidneys. And that's what's needed to create enough of a pressure differential to have ultrafiltration at the Bowman's capsule. The aorta is the largest blood vessel in the body. Similarly, the vena cava, the vein, the largest in the body, is where the renal veins drain into. And so, because there's a high flow of venous blood coming back, the chances of there being blood clots or impairment to that blood flow into the vein is low, and therefore you get efficient movement of blood through the kidneys. The vena cava and the aorta are only really found in the upper abdomen. When it comes down to the lower abdomen, you can see that they both split off. And so, automatically you're getting much smaller vessels, and therefore the blood flow going through is much lower because you've split it in half so that one goes down one leg and the other goes down the other leg. So considering just the artery, you can see here that the artery is much smaller, and so the amount of blood coming through into the donor kidney is a little lower. Now, of course, that doesn't really matter because the kidneys have a good capacity to cope with that. However, evolutionarily speaking, it makes much more sense to have a good continuous flow of blood into the kidneys. And so finding them in the upper abdomen is much better from a blood flow perspective. Also, you may hear of people developing things called DVTs or deep vein thromboses. These are blood clots that are found in the legs and they're in the venous system. So you can imagine how it can just work its way slowly up into the leg and then into the iliac vessels. So you can see here that the renal vein is actually at high risk of clotting off if people develop deep vein thromboses. That's not the case if the kidneys are found in the upper abdomen. So from a blood flow perspective, it is much better for the kidneys to be found in the upper abdomen. From a protection perspective, even found in the upper abdomen, there is a good amount of protection afforded by the ribs. So overall, there are good reasons for the kidneys to be found in the upper abdomen. This is not even including all of the embryological reasons why the kidneys are found in the upper abdomen, but that's a bit too complex for this lecture today. Another excellent question was, why does fluid not move naturally into the peritoneal space? Well, there is this space here, and what we were talking about here was with peritoneal dialysis. We use the peritoneum as a semi-permeable membrane so that we can cause dialysis of the toxins in blood which move into the peritoneal space and into that peritoneal fluid that we've inserted. But the question lies, well, there's that potential space there, so why doesn't fluid normally get in there? Well, it doesn't normally get in there, but it can get in there with pathology. And so it's worth having a little look at what the normal physiology is. Just to remind you what osmosis is. Osmosis is the movement of fluid, free water, through a semi-permeable membrane from an area of high concentration to low concentration of the water. And therefore, you can see here that there's a low concentration of water, i.e. a high concentration of solute. And so because the amount of concentration of solute needs to equalize, water will flow through so that the concentration here and here become equal. So let's think about it in terms of the body. So you've got two compartments. You've got the peritoneal space, which has got nothing in it at the moment. It's completely empty. And then you've got the blood. The blood has got water in it, but it's also got all of these other components, which include proteins like albumin, immunoglobulins, hemoglobin, and so on. All of these things that'll keep the concentration inside the blood vessel of solute much higher than the concentration of solute in the peritoneum, which doesn't have any solute at all. So you can see why water would naturally stay within the blood vessel and wouldn't move out into the peritoneum, because there's no need for it to go into there. But you can get pathological states where fluid does move into the peritoneal space, and this is a condition called ascites, and you see that the tummy swells up, and it swells up with fluid. If you have a look inside the body what it is, the normal body sits like this, and there's no fluid in that peritoneal space. But if you have a disease process, what happens is that this area fills up with fluid, and this is ascites. Now, why does it fill up with ascites? What diseases can cause that? Well, one thing that can cause it is the heart not functioning properly. If it's not pumping properly, what happens is that all of the blood vessels become backed up. And because they become backed up, the pressure inside the blood vessels becomes very high. And if you imagine having a sponge, if you don't squeeze the sponge, no water comes out. But if the pressure inside the sponge becomes higher, or you squeeze that sponge, what happens to the water? Well, it leaks out. And so that's exactly what happens in heart failure. Patients can become acidic or develop fluid in their peritoneal cavity because the heart's not pumping properly, the blood is all backing up, increasing the pressure inside the veins. That increases the pressure inside the capillaries, and then fluid leaks out of the capillaries and into the peritoneal space. That is what we call hydrostatic pressure. In addition to that, you can get conditions such as liver failure. And in liver failure, what happens is that the liver doesn't produce as many proteins. If you remember back to that picture about osmosis, if you don't have enough proteins, then the solute concentration inside the blood vessels drops. And because it drops, now you're going to get more free water moving across through the semi-permeable membrane of the capillary into the peritoneal space. And therefore, again, you're going to start to develop ascites. Finally, in conditions such as renal failure, what happens is that the body doesn't get rid of excess water. So the blood becomes very dilute, again, dropping the solute concentration of the blood. And also backing that blood up, engorging all the veins and therefore the capillaries. So you get both an effect of osmotic movement of fluid into the peritoneal cavity and also hydrostatic pushing of the fluid into the peritoneal cavity in patients with volume overload secondary to renal failure. So you can see that it's a fine balance in the body, and if you disturb that balance either in the hydrostatic method, i.e. increasing the pressure inside the veins and the capillaries, or by decreasing the solute concentration and therefore promoting osmosis, and therefore that oncotic pressure changes, you're going to cause fluid to move into spaces that it shouldn't normally, i.e. into the peritoneal cavity. These were fantastic questions. If you have any other questions, please leave them in the comment section below and I'll address them as soon as I can.